So, welcome everyone to the 39th session of the Ampok PG case presentation. And today, the presenter is Dr. Abhijit Bhaskaran from MBR Calicut. And we have two expert examiners today with us, Dr. Saurav Radhakrishnan from Amrita and Dr. Shoaib Nawaz from Malabar Cancer Center. So, without further delay, I think I'll ask Dr. Abhijit to start presenting, and all the other participants can put their doubts in the chat box, but please don't prompt him so that he gets deviated and is not able to answer in the right time. So, Dr. Abhijit, I think you can start now. I think you're mute. I'm not able to hear you. The person.
Sir, am I audible?
Yeah, you're audible. You can start presenting once you're ready.
Sir, am I audible now?
Yes, you're
Yes,
audible.
you're audible, doctor.
Please start. Please start.
Uh, One technical issue is there at our side. Kindly wait for 2 minutes.
There's a technical issue on that side, on the speaker side. Kindly requesting everybody to wait for 5 minutes.
Yeah, okay, sure.
Sir, am I audible?
Yes, you're audible.
Yeah.
Sorry for the inconvenience, sir. Good evening, everyone. I'm Dr. Abhijit Bhaskaran, second year medical oncology resident from MVR Cancer Center. So we'll proceed with the case discussion. Our index case for today is a 43-year-old gentleman hailing from Malappuram district in Kerala, a shop owner by occupation. He presented with the chief complaints of non-healing ulcer on the right lateral border of tongue for the past 6 months. The patient was apparently asymptomatic for 6 months, back when he incidentally noticed a non-healing ulcer on the right lateral border of tongue while he was doing a self-examination prompted by a persistent foreign body sensation in the particular region. The ulcer was initially about 1 centimeter in diameter and progressively increased to the present size over the past 6 months and was associated with excessive salivation, difficulty in speaking, chewing, and swallowing for the past 2 months. He also reports a weight loss of 4 kg over the past 6 months. There was no history of foul smelling discharge from the mouth, no history of decrease in mouth opening, no history of hoarseness of voice, no history of any other lesions in the oral cavity. There is no history of loosening of teeth, no history of any masses in the neck, and he doesn't give any history of chest pain, dyspnea, or hemoptysis. He is a recent smoker with a Pacquier index of 9. He's a social drinker, no history of tobacco chewing, no history of repeated trauma or sharp tooth, no history of ill-fitting dentures. He's a known diabetic on OHA, tab metformin once daily. There is no history of similar illness in the past, no history of previous surgeries or hospital admissions, and there is no family history of malignancies. He follows a mixed diet. So to summarize, our index case is a 43-year-old male, a non-diabetic on medication, recent smoker, presenting with the complaints of non-healing ulcerative lesion on the right lateral border of tongue, progressively increasing in size over the past 6 months. In the last 2 months, it was associated with excessive salivation, difficulty in speaking, chewing, swallowing. So going to general examination, patient was conscious, oriented, and cooperative. His ECOG PS was 0. His average build, there was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or edema. His vitals were within normal limits. So can I proceed to local examination?
Yeah, you can go. You were to give any differentials based on a history differential alone, in your opinion?
Based on the history, he's a 43-year-old male with history of smoking for the past 18 years. And he presented with a non-healing ulcer on the right lateral border of tongue. And he also has history of alcoholism. So my first diagnosis will be a squamous cell carcinoma of oral cavity, right lateral border of tongue.
Agreed. Any other? What are the other options? I mean, malignant. We'll keep to malignant. If you give a second DD, very distant ones, but any other options you would like to put up?
It can be a verrucous carcinoma also, sir.
Correct. Yeah. So these are the two main things. Squamous cell carcinoma as an invasive or a verrucous. Rarely it can be a lymphoma or other presentations can come with ulcerations of the tongue. So, but these will remain confined to these 2-3 things. Agreed. For a progressive ulcer, your first possibility always as a malignant this time, not talking about benign or non-malignant positions. Always keep it as a carcinoma, probably squamous cell carcinoma. Second is a verrucous. Distant possibilities being lymphoma. That's all. Okay, go ahead.
Proceeding with local examination. On inspection, his mouth opening was adequate, oral hygiene was fair, and on inspection, an ulcerative lesion on the right lateral border of trunk, anteriorly 1 centimeter from the tip of tongue, crossing the midline, and posteriorly 1.5 centimeter from the circumallate papillae. His tongue protrusion was restricted, and during this motion, it was deviated to the right side. There was no loss of teeth or sharp tooth. There is no other lesions in the oral cavity. There is no ankylosing. and there is no visible masses in the neck. Coming to palpation, on palpation, the findings of inspections were confirmed. A 4.5 into 2 into 4 centimeter ulcero-indurative lesion anteriorly extending up to 1 centimeter from the tip of tongue. The induration is crossing the midline almost up to the left lateral border of tongue. Posteriorly, it is 1.5 centimeter from the circumallate papillae. Floor of mouth is indurated on bimanual palpation, and there is no tenderness present on palpation over the lesion. And there were no neck nodes, cervical neck nodes palpable, and his jaw movements were normal. We did a video laryngoscopy for this patient, and it was showing normal findings.
So video laryngoscopy, no need to present. Basically, for the final exam, we won't be doing it. It's okay to present here, but generally this won't be there in the examination. One more thing, if I may say, is since he is a chronic smoker, if you had noted any smoking related oral cavity changes, you should say that, because you're trying to.
There was no staining of tooth and also his oral hygiene was fair. I checked
So,
for that, but there was no staining of tobacco.
Because you're trying to move the examiner towards a discussion on oral cavity carcinoma. So just make findings which will support yours. So it's something everyone can take a talk on. Okay.
Systemic examination, respiratory system, there was bilateral normovesicular breath sounds. Cardiovascular, per abdomen, and CNS examinations were normal. So my probable clinical diagnosis after history and examination is carcinoma, right lateral border of tongue with the T staging, either T3 or T4 with N0 disease. I'm not able to differentiate T3 and T4 without further investigation, sir.
So what will be the staging for the T staging? Since node is negative, what will be the T staging for this situation?
So
T2, T3, T4, what are the various?
So at this moment, I can only say it's either T3 or T4.
No, I'm just asking the stagings for the tongue. For the T1, T2, T3.
T stagings.
Yeah.
As per the HACC 8th edition, T1 is any lesion with the greatest diameter less than or equal to 2 centimeter with depth of invasion less than 5 mm. T2 disease is greatest diameter more than 2, less than or equal to 4 centimeter with depth of invasion less than 5 mm. And T3 disease is either size of 2 to 4 centimeter with depth of invasion 5 to 10 mm or more than 4 centimeter with depth of invasion up to 10 mm. T4 disease is more than 4 centimeter in greatest diameter with a depth of invasion more than 10 mm.
Yeah, okay. So I think that is clear to everyone. No, I mean, so this may sometimes be asked. If you get a short case, they may just ask what is the staging and why do you have difficulties in differentiating between two or the other? Or why do you think it is T3 or it can be T4? This is something which you will have to defend yourself. Why I think this is T3 or why I think it is T4. So yeah, go.
We did so can I go ahead with the investigations?
Yeah. So at this time, we are on a clinical level, you are dealing with a severe lateral tongue, probably T3 or T4, locally advanced with no nodal on clinical examination.
Yes, sir.
So anybody has any questions or anyone else?
So, Dr. Abhijit, so clinical examination, you have said it is probably a carcinoma of the tongue. So, any leads from the history? In the history part, why do you say any leads which prompted you to say that it is, say, a tongue carcinoma of the tongue?
He has history of smoking for the past 18 years.
Okay.
And he's an occasional drinker, and the sudden increase in size over the past 6 months.
Okay, fine. Okay, carry on.
If I may say one more thing, once you're seeing the oral cavity, just probably outright say that no leukoplakia when you're inspecting. You can say no lesions evident like leuko or erythroplakia seen. Is one more factor which you can make up. Yeah, kindly go.
So we did an MRI for this patient, which showed a heterogeneously enhancing lesion of size 4.5 into 2.5 into 4 centimeter with a depth of invasion of 21 mm. And the lesion is involving the genioglossus. It is also involving the lingual septum with focal extension to the opposite side. And the lesion is involving the superior aspect of the right sublingual space. And there was no extension to the base of tongue. And on the cervical lymph nodes, there were subcentimetric lymph nodes in the level 2, measuring 9 mm in the greatest diameter. And subcentimetric nodes were noted in the bilateral 1B, 2, 3, and 4 nodal stations. So we did a contrast CT for this patient, which showed no suspicious parenchymal, pleural, or mediastinal lesions. And we went ahead with an excision with the incision biopsy of the tumor, which showed a grade 1 squamous cell carcinoma. We also did a PDL1 CPS score for this patient, which showed a CPS score of 5. So after the preliminary investigations, I would like to give my diagnosis as a locally advanced grade 1 squamous cell carcinoma of right lateral border of tongue, T4A N1 disease, and a prognostic staging of 4A.
Okay, so how will you manage now? Any further investigations to be done, or can we move into the further management?
The CT, we already did a CT thorax for to look for lung mets and mediastinal nodes. It was negative. It was not showing any lesions. So I would like to go with management for this particular patient.
Yeah. So, Dr. Shoaib, anything further to ask?
Yes, yes, Abhijit, especially in head and neck cancers, when you present head and neck cancers for exam, I think you should be well aware of the statistics part. I mean, statistics means epidemiology part. Okay, so which is the most common cancer, and head and neck cancers come at what position in India?
In India, among males, it's the most common cancer in India.
Okay, so which is the most common subsite of head and neck cancers in India?
Oral cavities.
Okay, fine. So you should be also aware of the even the rates. Okay, so so that can come as question. Okay, so who is a never smoker?
Never smoker is the one who hasn't smoked 100 cigarettes over his entire lifetime.
Former smoker?
Former smoker is the one who has smoked over 100 cigarettes in his lifetime, but has for more than 12 months.
Okay, current smoker.
Current smoker is a particular person who is occasionally having more than or equal to 1 cigarettes per day or on occasional days currently.
Okay. Okay, then what is the field cancerization?
So field cancerization is an effect where a particular area of mucosa, when it's exposed to a particular carcinogen, like smoking in head and neck cancer, the entire area of that mucosa will be susceptible for developing dysplasia or malignancy. This effect was initially explained by Slaughter et al. In 1953.
Okay, fine. So, which are all the other cancers you expect in an head and neck cancer patient?
Other malignancies.
Yeah, other malignancies.
There can be GI malignancies, esophageal malignancies, and lung malignancies.
Okay, fine. Okay, so Saurabh sir, are we proceeding to the management?
Yeah, I think so. Just one more thing before we go. So,
Yeah.
tongue is an oral cavity cancer. What are the structures in the oral cavity? I mean, in the sense from an oncology perspective, when you treat
Oral cavity.
what does oral cavity entail?
It starts from the vermilion border of the lip. The subsites of oral cavity are oral tongue, buccal mucosa, gingiva buccal sulcus, hard palate, and lip. lip is also included in oral cavity.
Yeah. So the NCCN in general also mentions RMT as a part of oral cavity.
Yes.
Okay. So that has to be mentioned. Many times we miss that, but it is considered as part of oral cavity. I think in both ESMO and in NCCN nowadays they put up RMT as a part of the oral cavity. Yeah, so we'll go ahead with the management.
So for proceeding to the management, I would like to have a discussion with the multidisciplinary tumor board and with the patient. So since he is a stage 4A disease and young patient, 43-year-old, we would, and on biopsy, on CPA scoring, his CPA score is more than 5. I would also like to give him an option for immunotherapy, neoadjuvant immunotherapy prior to surgery, or directly proceeding with surgery. So based on the patient preference, I would like to go further.
So where is the data for the neoadjuvant immunotherapy? Which study?
So in the keynote 689 trial, stage 3 and 4A head and neck squamous cell carcinoma with a PDL1 CPA score of more than or equal to 1. There is data for giving neoadjuvant pembrolizumab. Initially, in the neoadjuvant setting, 2 cycles, 200 mg 3 weekly, followed by surgery. And post-surgery, with respect to the adverse pathological features, we'll either give CTRT or RT with pembrolizumab 3 weekly concurrently and up to 15 cycles of pembrolizumab. This has shown an absolute benefit of 21.4 months in EFS.
Yeah.
And it also showed a trend towards a better OS with pembrolizumab.
Yep.
The OS data is not mature yet.
Yeah, it's too early to say that. So this was an important trial. One of the initial times when immunotherapy has come into it. What are the options for a neoadjuvant chemo here? Since it's a locally advanced. Since this will be eventually a medical oncology exam, the question that will come up is there a role for neoadjuvant? I'm not talking about pembrolizumab alone. Is there a role of in this situation, instead of going with different options, role of neoadjuvant chemo and other things will be asked? You can go on.
Neoadjuvant chemotherapy, we can give induction chemotherapy in this patient, but when neoadjuvant chemotherapy, it was compared directly with CTRT. For example, in DECIDE and PARADIGM trial, there was no added benefit with giving neoadjuvant chemotherapy.
Agreed. So that is one of the points which you have to remember. There is no specific benefit from their giving it only in very selected situations where you think the post-radiation surgery might be compromised. If it is required, in some situation, if it is required, if the surgeon feels that the post-surgical, maybe due to already existing marked submucosal fibrosis or others, and he feels after RT, if at all he is going to read a surgery, it might be difficult to control and they would prefer a neoadjuvant chemo. That's one of the areas, but because other than that, upfront, there is no outright evidence for a neoadjuvant chemotherapy other than immunotherapy. Right, go ahead.
So for this patient, we went ahead with primary surgery. He underwent subtotal glossectomy with right marginal mandibulectomy, with right modified radical neck dissection with the removal of IJV, spinal accessory nerve and subclavian SCM. We did a left selective neck dissection on the contralateral side, and reconstruction was done with right PMMC plan.
Okay, this is a surgical part. And go on.
So his post-op histopathology, it was the tumor size was 5 into 3 into 2 centimeter with a depth of invasion of 1.9 centimeter with a histological squamous cell carcinoma, conventional keratinizing type with grade 2. Perineural invasion was present within the tumor. LVSI was absent and worst pattern of invasion was 5. All the margins were negative for invasive tumor. And among the lymph node excised, a total of 56 lymph nodes were excised on right side, and out of which right level 2, level 3 lymph nodes were positive, and they were showing extranodal extension. On the contralateral side, out of the 41 nodes dissected, 1 node was positive with a size of maximum size of 1 centimeter, but there was no extranodal extension on the left side. So his Stage actually got upstaged to PT4A M3B post surgery.
Dr. Shoaib?
So, I think you have mentioned what is the performance status of the patient?
ECOG PS0, sir.
Okay. So, you told like you want to give neoadjuvant pembrolizumab, right?
We gave them an option, sir, but they were having logistic issue for immunotherapy, so we went ahead with upfront surgery.
Okay, fine. So you were talking regarding keynote 689. So what are all the flows you could find? What are all the things against 689? Any takes on that?
So in keynote 689 trial, they didn't include N3 disease, sir. They only included stage 3 and stage 4A. 4B was not included in keynote 689 trial.
Sorry, I missed you, I think. Anyway. Okay.
Sir,
So yeah.
they didn't include stage 4B in keynote 689 trial.
Okay. Anything regarding the timing of pembrolizumab? So they have given neoadjuvant and adjuvant, right?
Both neoadjuvant and adjuvant, yes.
Yeah. So we cannot be sure which thing has played its part.
Yes,
Correct.
sir.
So whether
Yes.
it is neoadjuvant or adjuvant. Okay. So what are the risks involved in giving neoadjuvant chemotherapy or immunotherapy, especially in head and neck cancers?
There will be a delay in receiving local therapy, sir, because local control is important and it results in prognosis in head and neck cancer. So while we are giving neoadjuvant pembrolizumab, we are waiting for 6 weeks for the 2 cycles. So there will be delay in getting surgery and the local therapy.
So the delay, what do you mean by the delay? What is the complication you expect when there is a delay?
Uh, it can progress, sir, if there is a delay.
Yeah. So there can be an accelerated population of the cells if they are resistant, if they develop resistance in between. Okay, so we are delaying the curative intent of the treatment. Curative intent treatment, that is surgery. Okay, so there is always a possibility of progression. So whenever you are giving neoadjuvant, this has to be there in your mind. Okay.
So can I proceed, sir?
Yeah. Is the patient cisplatin eligible?
He is cisplatin eligible, sir.
So what is the criteria you look into?
So his creat clearance is more than 60 ml per minute. He doesn't have any neuropathy, any cardiac failure, or any sensory neural hearing defect. So he's eligible for cisplatin.
What is this criteria called?
Galsky criteria.
Okay. What was it originally developed for?
CA bladder, sir.
Yeah.
Okay, fine, good.
Good. You know that. So kindly remember that there is the cisplatin criteria has a name actually to it. Okay, everybody please note that. And although it remains very genitourinary, it still remains the standard of using cisplatin, but it can be used anywhere. Basically, what we clinically do, but it has a name and it has a specific elements to it. Please do remember that. Okay, go ahead.
So based on the post-operative pathological staging, he's currently planned for adjuvant chemoradiation, sir. He's awaiting treatment at the moment.
So what are the indications of giving chemo in the adjuvant setting? I mean, chemo radiation in head and neck cancers?
Based on that Bernard Cooper meta-analysis of EORTC 22931 and RTOG 9501, if the patient is having extracapsular extension or margins positive, there is a benefit in giving chemoradiotherapy. If there is other adverse pathological risk factors like LVSI, perineural invasion, more than 2 lymph nodes positive, or upfront T3, T4 stage, there's no benefit with addition of chemotherapy with radiotherapy. So we'll give adjuvant radiotherapy.
So, what is the practice in your center? You give only for those two indications, or other soft indications are also included?
So we are giving for margin positive and extracapsular extension.
Okay. Okay, Saurabh sir.
Yeah, I think, okay, so that is fine. So for chemoradiation, what are the options available? So one is cisplatin, agreed. The doses of cisplatin?
We give a 3-weekly schedule, sir, 100 mg per meter square on day 1, day 22, and day 43.
Okay, what are the other options available? That is the standard regimen, I agree with that. What are the other options available?
Other options that are available are weekly cisplatin 40 mg per meter square. And if elderly patients, we started using nimotuzumab in our center weekly. And another option is using cetuximab and weekly carboplatin 1.5 to 2 AUC.
So any combinations which we can give again for a cisplatin ineligible situation, or even cisplatin eligible? Is anything can be added?
Cisplatin eligible patients, based on the TMH trial which came up recently, we can add nimotuzumab.
Yeah, so that is one more option. You can add nimotuzumab to a platinum also to increase, usually to cisplatinum, but one can extend that to include any platinum. But yeah, so the essential options is cisplatinum, nimotuzumab, and cetuximab, and carboplatin. So these are the concurrent options which is available. Nimotuzumab dosage. Abhijit, can you hear me?
Yes, sir. I'm not remembering it. 200 mg, sir.
Yeah, it's a flat dose, 200 mg.
Flat dose 200 mg weekly.
Yeah, cetuximab dose.
Cetuximab will give a loading dose of 400 mg meter square 1 week prior to starting RT, then weekly 250 mg per meter square.
Yeah. So, what are the things you will watch out with cetuximab administration?
So he can have hypersensitivity reaction with cetuximab. So initial loading dose will give over 120 minutes. I'm not sure about that, sir.
Yeah, approximately 400 mg you have to start slow. Over 120 minutes is fine. But to watch out for hypersensitivity, it can be fatal anaphylactic reactions. Very severe, can lead to cardiac arrest. No other, very rarely with other antibodies. Cetuximab is particularly very well known for that. Extremely uncommon, but very well defined. So that's why cetuximab never really that commonly took over in many centers because of the higher risk of hypersensitivity. Nimotuzumab scores over that. It has relatively no hypersensitivity reactions.
Okay.
So yeah. So coming back to cisplatinum, how will you administer? Can you give an order for cisplatinum?
So
For a concurrent chemo, I'm not talking about for both the regimens, 40 mg and or 100 mg.
So 100 mg per meter square, we have to prehydrate before pre-medication and prehydration has to be given before administering cisplatin. So the pre-medication, since cisplatin is highly emetogenic, we have to include dexamethasone. We give aprepitant, dexamethasone, palanoseptone, and prehydration with 1 liter of NS. Then we'll give cisplatin 100 mg per meter square in 500 ml NS over 1 hour. And as a part of post hydration, we give 100 ml of 20% mannitol and 2 gram magnesium sulfate and 20 milliequivalents of potassium chloride as post hydrate.
Okay, so so you generally for a high dose cisplatin, triple antiemetic regimens will be there.
Yes.
Okay, so aprepitant, dexamethasone, and you are giving palanoseptone. Yeah, yeah. So any specific advantage of palanoseptone in this situation?
So it has a prolonged action, sir.
Yeah, so delayed nausea and vomiting may be better controlled with in a high dose cisplatin like the one which you are using. There is a higher risk of delayed nausea and vomiting. So that is where palanoseptone has a specific role. Any other options of anti-emesis?
Olanzapine we'll add in some cases for high dose cisplatin.
Yeah, we have the JIPMA trial. where the use of
Low dose olanzapine.
low dose olanzapine had a very good added advantage and an anxiety ameliorating effect. So very cost effective. It's definitely worthwhile trying out in a high dose regimens like that. We sometimes use it in high dose, it's relatively well tolerated. What are the other options? Supposing with this patient has vomiting and for second cycle, what will you do? Is there anything higher you can try out? Other newer drugs which are available? What is a nutipetant?
Nutipetant.
What is nutipetant?
Sir, it's a NK1 inhibitor.
So how will it help out?
So it has a central action. I'm not sure about the mechanisms.
So I learned that it's very important because it is one of the options available. Occasional patients, see, it's not something which you can use upfront. The costs have come down more or less same as an aprepitant now, but nutipetant has certain areas where it might act if aprepitant has the next generation with central and peripheral action. So that is a specific advantage that it has over the other areas. So what about the other doses of cisplatin which we are talking about?
Weekly cisplatin, sir, 40 mg.
So do you follow the same protocol?
No, sir, because for a weekly cisplatin dosage, we'll avoid the mannitol and we'll reduce the hydration to 1 liter. We'll just make sure that the patient, while he's getting cisplatin, his urine output is 100 ml per hour.
Yeah. So which of these is usually used in trials and is considered as standard? Which of these protocols?
3 weekly protocols.
So 3 weekly protocol is the standard. When you are asked just the dose alone for a concurrent chemo radiation, just say the 3 weekly protocol dose alone. Because generally for all studies and in general in textbook standards, it's always given us. But if you see guidelines in most institutes around India, most of them use the weekly regimen. Saves time and more patient friendly. And there has been no head-to-head comparison between both in terms of a phase 3 trial. Carboplatin protocol?
Carboplatin, like it's not, since we are giving it an AUC of 1.5 to 2, we won't give.
How will you calculate AUC? Just one more question. How will you calculate the dose of, for AUC 2, how will you calculate the dose of carboplatin for the patient?
That AUC into GFR plus 25.
Yeah, AUC into GFR plus 25. Agreed. So that is we should know that. Okay. So so AUC 5 means you give appropriate AUC and calculate. Fine. So how will you do it?
So we'll given 500 ml NS, we'll infuse over 60 minutes.
Yeah. So what all things are carboplatin compatible with?
Sorry, sir?
The fluids with which you can give carboplatin, in which you can
5% dextrose and NS, sir.
Yeah. So cisplatinum only with NS. I'm not very sure the 5D. Oxali will only go with some because discussing platin, oxaliplatin will only go with 5% dextrose. So carbo is actually compatible with both, although traditionally it's always given as 5% dextrose. Okay. Dr. Shoaib, anything else?
Why AUC? Why are you using AUC for carboplatin? Why not BSA? Abhijit, can you hear me?
Yes, sir. Yes.
Got the question, no? Why don't we use mg per meter square?
So because clearance of carboplatin is based on the GFR, so we are using AUC.
Yeah. So it is the excretion is GFR dependent. Okay. So that's why we are using that. What is the formula for for calculating this? What is the name of the formula?
Calvert formula.
Okay. Sir, please proceed, sir.
So what are the side effects with, I mean, UCT you may not get, but you mentioned cisplatin side effects. Since we are there, sometimes patients may be elderly and you may end up still getting carboplatin toxicity. So what all do you expect with carboplatinum?
Carboplatinum main side effect are hematological side effects, sir.
Hmm.
So most pronounced will be the thrombocytopenia.
Myelosuppression also it can occur, but yeah, most pronounced with
Myelosuppression is
thrombocytopenia.
mostly thrombocytopenia.
Agreed. So anything else?
Sir,
Cisplatin, I
is
think we mentioned, no? Autotoxicity, neurotoxicity, and
autotoxicity, neuro and
MSS and other things. Agreed. And cetuximab we have discussed. Nimotuzumab, I mean, it doesn't cause much of an issues anyway. So yeah, what was the trial for nimotuzumab?
sorry, sir.
Which was a trial which established nimotuzumab as the one of
With
the
CPRT.
Yeah.
With that trial from TMH, sir, in locally advanced head and neck squamous cell carcinoma, when CTRT with cisplatin was combined with weekly nimotuzumab 200 mg. So
What did
initially,
it show?
sorry, sir.
What did the study show?
Initial analysis showed a PFS, loco-regional control, and DFS benefit, but the recent 10-year long-term analysis showed an OS benefit of 11%, if I remember correctly.
There is a the scientific part of it, the trial showed an OS benefit, and it's very well tolerated drug.
Yes.
Beside those 2 points, from the other major thing with nimotuzumab is that it's part of the government schemes. Okay, I think most of you, those who are in government, I think Dr. Shoaib might be knowing. It's part of the Ayushman Bharat scheme. So you get the 3 antibodies which are approved in general till now for Ayushman Bharat is rituximab, trastuzumab, bevacizumab for some reason is there, and nimotuzumab is the only other antibody which is approved for usage in Ayushman Bharat. No other antibodies will not available free of cost in that sense is there. Yeah, Dr. Shoaib, you can.
Yeah, yes, it is there, but
Yeah,
we
so
don't usually use it.
yeah. So from a social point of view, also it's important because if you have a patient whom you cannot give cisplatin and for some reason you cannot use carbo, Nemo is a thing which is there in our government setup, so it's available for them free of cost. Okay, so keep that in mind because I don't know, many of us will end up working in situations in government where to see what you can give to the patient also becomes more important, and sometimes we may have to make do with many things. Yeah, Dr. Shoaib, please go ahead.
So we were talking regarding the toxicities of carboplatin, right, Abhijit?
Yes, sir.
Yeah, have you seen any hypersensitivity reactions
So
to
mostly
carboplatin?
with challenging carboplatin on the later lines, we have seen anaphylactic reactions, sir.
You have seen. So
Yes.
at what cycle? I mean, which number of cycle? Cycle 1, 2, 3.
After 5 or 6 cycles, sir, especially
Yeah.
in case ovaries when we are rechallenging it in the later lines, we have
So
seen.
yeah, that is one thing special for carboplatin. You see those reactions not early, not with the first or second cycle. You see it with the fourth, fifth, or sixth usually. Okay. So the plan is, so you're planning for adjuvant chemoradiation, right?
Radiation, sir.
Can you hear me, Abhijit?
Yes, sir.
Hello.
Yes, sir.
Yeah. So what are the things you will take care before starting chemoradiation?
So we have
How will you
to.
counsel the patients? What are consultations you will take?
So before going for chemoradiation, we'll counsel him regarding. We'll get a nutritionist consultation, dentist consultation, and a deglutologist consultation, and an audiologist. We'll get a pure tone audiometry also done because we'll be giving concurrent cisplatin.
Okay. Then what is the schedule of chemoradiation that you're following in your institute? What is the dose?
So radiation, we are following the conventional fractionation schedule only. We are giving 70. Since this is an adjuvant setting for N3, because this patient is having N3B disease, for that site alone, we'll give up to 66 gray. Rest will go up to 60 gray, 2 gray per fraction over 5 to 6 weeks. And chemotherapy, as I've said before, cisplatin on day 1, day 22, and day 43.
Okay. Okay. Fine. So, how will you follow up the patient? I mean, during the treatment.
So during the treatment, like weekly once, we'll review the patient to look for toxicities like oral mucositis. We'll assess his intake and output, whether there is any dyselectrolytemia, whether he's developing radiation-related mucositis, xerostomia, and all.
Okay. Anything else?
So like we have to look for basic hematological investigations we have to do during chemoradiotherapy. A hemogram we'll do once in 2 weeks.
Yeah. You will be recording his weight also, no? To
Yes.
assess his nutrition status. So that is important because he has to get all 3 cycles of cisplatin, right? So maintaining the nutrition during radiation for head and neck cancers is important. So you have to make a chart for the weight and you have to record it. Okay. Okay. So what would be the minimum dose of cisplatin should be given?
200 mg per meter square.
Yeah, sure. So you should make sure that the patient has received at least 200 milligram per meter square of cisplatin in total. Okay. Yeah, good. Yeah, Sarab sir, please sir.
Since we are, I'm sorry, you can hear me, no? Yeah, so we are
Yes.
going with this. I would like to ask, immunotherapy, any role? Especially, I mean, since head and neck, it's nivolumab, which gets the most about this one. Anything new regarding use of this is an individual who can have a high risk of recurrence. So, any role of anything going on regarding nivolumab?
Yes,
kind
sir.
of post-operative setting?
Nivo post-op trial in stage 4 locally advanced head and neck carcinoma.
Mm.
Post-system, if high-risk pathological features are present,
Mm.
we'll give nivolumab 240 mg twice weekly along with CTRT. So along with CTRT, we'll give 3 cycles of nivolumab and we'll continue nivolumab maintenance, adjuvant nivolumab up to 12 months. So when compared to CTRT alone, this has shown a DFS benefit, an absolute benefit of 10.6% and a positive trend towards OS benefit in the Nivo post-op trial.
What about PDL1 status?
No, sir. Nivolumab, PDL1, irrespective of PDL1 status.
So this was trial, if I remember correctly, was given to all comers. So this was a trial which was there for all comers, if I remember correctly, irrespective of their PDL1 status. And as of now, there is a DFS benefit. So, I mean, this would be an ideal patient for this situation. So that is a newer thing which has come in, nivolumab in a high risk patient in as an adjuvant setting for concurrent with concurrent CTRT and subsequently continued for a total duration of 12 months. Yeah. So nivolumab, how do you administer? Anyway, since we are going into immunotherapy, nivo administration.
Sir, in 100 ml NS over 30 to 45 minutes. I'm not
What
sure.
about the ideally they say it should be within 15 to 30 minutes.
Okay.
Because faster you give it, better the peak getting. But pre-medications?
No pre-medications required, sir, for nivolumab.
So generally no pre-medications required. If patient had a reaction, what will you do? Second cycle?
So depending upon the grade of reaction.
It's a mild reaction. So you're continuing.
It continues.
Yeah. So what will you give next time pre-medication? Or will you give next time also without pre-medication?
We'll, I'm not sure, but I'm sure about that.
So nivolumab and pembrolizumab, both the immunotherapy in general, if you're giving, you are supposed to give, if there's a reaction, next time you're supposed to give a anti-allergic things. You can give chlorpheniramine, Avil or something like that. You can also give a low dose steroid if you think it might be, if you think it's going to be beneficial. Generally, what is done is, what is recommended is a 25 milligram of hydrocortisone along with antihistamines. to give a 25 mg of hydrocortisone, not 100 mg, 25 milligram of hydrocortisone. This is in a patient who has had a mild, some degree of reaction, and where you think continuing the immunotherapy is fine. So this is a permitted this thing for the usage of steroid as pre-medication in an immunotherapy. Upfront, it is not required, but generally after reaction, you can give a low dose steroid 25 mg with this one. So, and Nivo is given usually over 15 to 30 minutes. Pembro, because of the need to attain the peak concentration and maximum effects. Side effects of Nivo?
I'm not able to recollect, sir.
So, okay, you're not much used.
Reactions can occur, sir. Rashes and all can occur.
Yeah, so basically remember for Nivo, when you are having any immunotherapy of this thing, mostly it will be something like an autoimmune problem, you know. So whatever autoimmune, colitis, hepatitis, I mean, just saying out, but commonest thing which is generally observed by most people which use it is thyroid dysfunctions. Initially, there might be increase in thyroid hormone levels, but may not be symptomatic. Eventually, by the so after 2-3 cycles, patients would eventually go into hypothyroidism. So mostly these has to be checked into before seeing. So check the blood sugars regularly, check the TSH and thyroid hormone levels, check cortisol levels to rule out any hypo or hypercortisolism which can occur. Check the skin, ask for specifically for diarrhea, which can be due to colitis and other factors. So, so depending on the grade and severity, you will have to take measures for the subsequent cycles. So remember something, for most of the immune toxicity, when they ask, think of an autoimmune, what are the manifestations, and you will get away with both. Commonest always to remember is thyroid, and it can cause both thyrotoxicosis and or hypothyroidism. Generally, on long term, it is hypothyroidism which will come. Mostly these have to be picked up in the blood, not wait for the patient to become symptomatic. Another endocrine problem many of them have is hypo or hyperglycemia. So not very common, but some patients can end up with hypo or hyperglycemia, whether or not they are diabetic. So again, has to be closely planned. The rest are whatever immune dysfunctions which can be lead to this dermatological problems, hepatic immune problems, intestinal immune problems, and all the others. So remember that during this. So head and neck also means nowadays immune therapy has come in. So this is something which we will all have to take into account going forward. So yeah, Dr. Schweib, you can go now.
Yeah, so it's always advised to do a baseline thyroid TFT. For head and neck cancers. We usually do that, but for those who are planning immunotherapy, definitely a baseline TFT is always advised. So we have to keep that. Then why, Abhijit? Why is told that hydrocortisone? Why not Dexa here?
Yeah, that's a good question actually. Even I forgot to ask that.
The effect of hydrocortisone is more short-acting compared to dexamethasone.
So why that? Why are you not giving Dexa here?
Interfere with that. Interfere with the efficacy of immunotherapy if you are giving a lot of steroids.
Yeah, good. So whenever possible, we try to avoid steroids along with immunotherapy. Okay, so whenever it is needed, we give short acting. Okay, so that's the concept there. Okay, good.
Yeah, that's good. So basically, it's inducing an immune response. That's what Dr. Shoaib meant, you know. So if you give a steroid, it just doesn't allow that. And Dexa is pretty long acting. It's very well known for its lymphopenia effect. That's why you long-term action and lymphopenic effect. So that's why we avoid using it. You simply don't get an immune response with it. So if at all you are going to use a steroid, use a low dose. So going forward, I think for the upfront management, that is fine. Anything specific to add, Dr. Shoaib?
Nothing. I felt like you should be well aware of. I mean, to Abhijit. So the initial part of whenever you present a head and neck case, so questions can come with respect to history and all those initial part, no risk factors, history, all those things. Okay, so we didn't have so much of discussion in that aspect during this case presentation. So I think you would be reading that also. So please read all those things.
Yes.
So definitely that will come as questions. Okay, so
reiterate what Dr. Shoaib said in the beginning, it is the most common tumor in India, and it's very big. It's a common tumor by a huge margin. Okay. The head and neck bulk of tumor is like, I think 30% or something, that 30 to 35% of the total malignancy burden, I think, in India is on head and neck. So we have to know the epidemiology and all the other factors very well. And it's almost like, with few exceptions, almost entirely related to lifestyle and risk factor modulation. So which play a very important role post-operatively also. Anyway, before closing, let's add one more thing, because it's a head and neck tumor. What about HPV? Where is it important? What are the things for a head and neck tumor and HPV connection?
So HPV, most commonly HPV 16. It's more commonly found in head and neck oropharyngeal squamous cell carcinoma. So in oropharyngeal carcinoma, if the patient is HPV positive, his prognosis is better compared to an oropharyngeal carcinoma with HPV negative. It's around a difference of 80% to 25%. And association of tobacco with HPV positive carcinoma is less compared to HPV negative. It's around 90% in HPV negative and around 50 to 60% in HPV positive. And comparatively, prognosis is better in HPV positive oropharyngeal carcinoma. And the presentation also changes, sir. In HPV positive oropharyngeal carcinoma, the patient presents with a early stage primary with extensive nodal presentation.
Okay. So one more thing, since just before this thing, other than smoking, what are the other epidemiological factors with oral or head and neck cancers? The important ones, if we can mention.
So alcohol, heavy alcoholism, that is more than 50 grams of alcohol per day, increases the risk by relative risk by 5 to 6 times. And another, when it comes to nasopharyngeal carcinoma, EBV infection is a cause, is a viral etiology. And other forms of tobacco, so like
other than tobacco and alcohol, common other thing, diet.
A diet.
Yeah, so smoked foods have a higher correlation with this thing. We don't use, I mean, we are not much used in this southern India. We don't have much smoked food usage other than, but if you go to Northeast and other areas, you'll start using a lot of smoked food usages are very common.
And salted meat are also
salted, cured, salted, smoked, long duration meats have a association with head and neck cancer. So that is something to remember. I think the highest percentage of head and neck cancer is, I think, Meghalaya or Nagaland. I don't remember now. I think Kohima had the highest. I'm not very sure. But yeah, they have a very high proportion of head and neck cancer. So it's not just tobacco, it is there. Tobacco, maybe chewing, oral tobacco usage is there. In addition to that, you have the dietary aspects also coming. So that is one more factor always to remember. Food, the type of diet and food is very important. So smoked, long cured, long stored meat has a very close association with this thing. Similarly, nitrite foods also have some association with head and neck cancers. So some of the preserved foods, which, I mean, like, you know, we got frozen foods and others, to some extent have, not all of them have it. Some of them have an association with it. But predominant three are tobacco, alcohol, and dietary habits of storing food, actually, and certain ways of cooking food. So these three, other than the other known factors like HPV and others, but common three things one should always, for epidemiology, is these three things. And this is something which I think everyone should know. If you are getting a head and neck case, this will always be asked, because highly preventable, but the most common cancer burden in India as of today, and I think for the past 20, 30 years, this has been the same situation. Not much change in the incidences of this has been seen in this situation. I think if you take 20-year back data also, it was head and neck, and the numbers are not really changed. Unlike cervix and other tumors which have come down, head and neck has not really shown much changes. Only we're saving more patients probably with more treatment, but the incidents have not really come down. I'll hand over to Dr. Shoaib for the final words.
Yeah, so I think you should be well aware of the five most common cancers in India and in the world. Okay, and even so examiners can ask you what is the ASR of these cancers. So that epidemiology part, definitely it will come at some point of your presentation, case presentation. So please, everybody should be well aware of these epidemiological aspects of the five most common cancers in India and in the world, and especially in our part of the world. Okay, so that is very important. So, so I think we can wind up, no, sir?
Yeah, Dr. Shah. Thank you, Dr. Shah.
Thank
Over
you,
to
sir.
Thank
you.
you.
Yeah.
So,
Thank you so much. Thank
Just
you so
1
much.
minute. I think somebody asked some questions in the chat. No, somebody was asked. You said you were asking. No.
Yes, I'll
Anybody?
just read that out. And I
Yeah,
think,
yeah.
sir, one more important area is that, like, when we were giving our exams, is some discussion on metronomic therapy also
Oh, yes.
is
We
very
forgot
much
about
importantly head neck
it.
cancer. And I think there were some questions here on in why in clinical examination it was like T3, T4. Can we keep a bar or we need to commit one?
Definitely. For a clinical thing, yes. But once you examine and set, you have to give a final answer, whether it's T3 or T4. Unless you have specific doubts why you cannot give it and may require imaging, that is fine. On a history taking and inspection, till then you can give a bar thing, T3 or T4. Once you have palpated and completed the examination, you have to give a final answer. Why it is T4 or why it is T3. And if you are not able to make a decision, why you are not able to make a decision. So those are the factors, because leaving aside oral cavity, sometimes we may not be able to give completely that it is T4 or T3 or stage 2 or stage 3. As long as we have an explanation ready, it will be accepted. From history and inspection, it's fine to give T3, T4.
Right, sir. And if a patient tongue is deviated and with restricted movement, isn't that itself a stage 4 saying muscle involvement?
That's a good question, actually.
Sir,
But yeah, go ahead.
one doubt is like in AJCC 7th, it will be T4, but as per the new AJCC staging, that extrinsic muscle involvement doesn't come under T4A.
Okay.
For tongue.
Right. And then about so even this like we discussed with about all the radiosensitizers. I think docetaxel, there was another trial, so that's why Dr. Syed has asked about docetaxel being as one of the concurrent radiosensitizers.
Yeah,
I think there was a
docetaxel has
team.
a radiosensitizing action. The main issue with the docetaxel usage is it can be used, there's nothing wrong. But cisplatinum has been classically used. Second is docetaxel is a much higher myelosuppressive agent. And the problem with when you give a radiosensitizing agent is you are giving it in a situation where radiation is the primary treatment. And what we are adding on in the systemic treatment is a sensitization to it. The patient ends up with a complication as a myelosuppression or others, you will end up delaying the radiation part also. But in a situation where nothing else you cannot give and patient is not affordable for an antibody, yeah, docetaxel is a fine option to give as a radiosensitizer, even in head and neck. In fact, one of the induction treatments or in a sort of neoadjuvant chemo was for a long time was a triple regimen if it was used in younger patients, would have been dosi, cisplatinum and 5FU regimen. So, and docetaxel is known to have a radiosensitizing effect, but generally not used because of its side effects. And Uditya mentioned, because he mentioned OMCT, Abhijit, what is OMCT?
The oral metronomic chemotherapy, sir.
What is the principle behind it?
So principle for metronomic chemotherapy is like continuously administering a low dose of a chemotherapy drug. It mainly targets the angiogenesis part of tumorigenesis, and it creates an immunomodulation so that the tumor progression is limited by administering a low dose over a longer period of time.
So what is the trial in head and neck?
In head and neck, we have a trial from TMH from Vijay Patil, sir. So there, oral metronomic chemotherapy with methotrexate 15 mg per meter square, 2 weekly plus celecoxib 200 mg per day was compared with 3 weekly cisplatin.
And what are the conclusions of the trial?
Non-inferiority trial, sir. So non-inferiority was proven for OMCT.
What was the other trial from TMH again by Patil in head and neck?
Sorry, sir.
What are the other trial? Same to this thing, OMCT and
Added low dose nivolumab, sir.
yeah. What are the dose given?
20 mg flat dose 3 weekly.
Yeah. So these are two very important trials in the sense of they are very low cost options which are at least non-inferior. In situations where we may not be able to give the full dose regimen to the patient. Okay,
Yes,
I think
and
know about the trial at least for the next 2 years. Those who are going for exams, it's if you are going to get a head and neck case, many times it might come. Somebody might ask regarding this trial if you get a head and neck case, because these are very major trials which have been internationally published and accepted. And so questions can be asked on these two trials if it comes to a discussion on further treatments and others, or to a stage 4 treatment, or where patients PS is poor or other situations come up, it can be asked. So kindly just look into the trial, know the major findings and what was done in the trials. Somebody else asked?
yes, and the last question was like management of skin toxicity in immunotherapy.
Yeah, it's a very difficult question to answer. Depending on the severity, one may have to stop giving it, or what you call that. There is a moisturizing agents, and there is a combination available by one of the companies that given using certain agents which can be mixed together and give. It's very difficult to measure. Mostly what it's all this thing is usually using a moisturizing agent to maintain the oils in the skin, and nothing else really works. So patient has to go through that, but there is a regimen. Keep the skin neat and clean, keep it dry, and apply moisturizing agents. That's about what I can say. Anything else, Dr. Uditya, or anybody else that? Anything new regarding skin management and toxicity?
I'm also not sure, sir, actually, beyond most.
One of the guys had met me actually from the, this is not from a scientific point of view. They have a skin manifestation management, this thing, they are putting up this thing for that. I think it was for the, I don't know which company came along, but they are saying they have a skin management issue with one of the immuno, not for nivolumab, but one of the other immunos. So remember something, OMCT is predominantly anti-angiogenic. It's more of a tumorostatic than a tumoricidal. It's low toxic, can be used across all PS, and very little side effects or toxicities are expected of the OMCT. Some patients respond very well, not just in head and neck. It's across the spectrum. Some patients do very well. Triple negative breast cancers, certain forms of endometrial cancer sometimes. So the data there is less. Ovary. These are some areas other than head and neck, classically head and neck, where patients have a benefit from these drugs. Okay, Uditya, thank you.
Sure, sir. Thank you so much. I think I feel that Dr. Abhijit has answered really well, and we have covered all the important points and trials as well. So thank you so much to Saurav sir and Shoaib sir to making this possible. And thank you, Dr. Abhijit. Thank you, Ampok, for giving us the opportunity to learn. So I think with this, we'll close the session and come back again next month.
Thank
Thank
you.
you. Thank you all. Thank you all. Thank you.
Thank you, Dr. Shah.
Thank you, sir. Thank you. See you.